Okay, well, hello everyone. We're going to go ahead and get started. Thank you so much for taking the poll for us. Um, we're just going to go ahead and get started now. As you all know, this is the first webinar in a two-webinar series for the boot camp boot camp training coming up on November 1st. Today we're going to discuss some of the basics of Parkinson's disease and some special considerations for exercise instructors. Before we get started, just wanted to tell you a little bit about the Brian Grant Foundation. I am the executive director of the Brian Grant Foundation, and our mission is to empower people impacted by Parkinson's to live active and fulfilling lives. And we do that through programs that focus on exercise, nutrition, and emotional support. As I'm sure you can imagine, the boot camp is one of our exercise initiatives for people with Parkinson's. The boot camp is a high-intensity exercise class developed for people in the early stage of Parkinson's with higher functional levels. We'll talk about that more in the in-person training on November 5th. But essentially, when we talk about high-intensity exercise class for people in early stages and with higher functional levels, we're really looking for people who are able to walk without an assisted device or a cane, and people who are able to get up and down off of the floor without assistance. And again, we'll talk about that at the November 5th training in more depth, but I just wanted to give you guys a little bit of background. The aim of the boot camp is to get people with Parkinson's exercising at their highest intensity level at the earliest stages of diagnosis, using movements that may help counteract the loss of specific motor functions. And today, we are going to talk you through a little bit about Parkinson's disease and some considerations for exercise instructors. And I'm going to turn it over to Dr. Matt Brodsky. He is a neurologist and movement disorder specialist at OHSU Parkinson Center, and we're extremely grateful and appreciative of his role also with the Brian Grant Foundation as a medical advisory board member. And with that, I will turn it over to Matt.
Well, thanks, Katrina. Welcome, everyone, to this webinar. And I've been asked just to go over some basics about Parkinson's 101, if you will. But certainly want to allow time for questions and answers at the end of this. So just as a primer, Parkinson's disease is a neurodegenerative condition that affects the central nervous system, the brain. And while there are a number of different changes that occur progressively in the nervous system, one of the predominant ones is that cells that make one of the chemical messengers called dopamine are progressively lost. There's a progressive loss of function of those cells. There's less dopamine that is made and released by those cells. And dopamine release in the brain is intimately involved in a deep circuit in the brain called the basal ganglia. And the basal ganglia help coordinate movement. They help initiation of movement. They help smooth movements persist, voluntary movements. They're also involved in automaticity of movement, so that, for example, when people are speaking or when they're eating food or when they're walking, things we don't consciously think about, the basal ganglia circuit is at play, ensuring smooth, coordinated movement. And that system starts to break down when there's a loss of dopamine in the brain. And so for your purposes as instructors and working in exercise, I think that's one of the main things to keep in mind. And again, while there are other changes, for example, other neurotransmitters that shift in Parkinson's, it's really the dopaminergic system that's affected to the largest degree. And so when there is progressive loss of these cells that make dopamine, it leads to the cardinal motor signs and symptoms of Parkinson's. And I'll just note that while you see on the slide here that Parkinson's is a condition that progresses over time, that progression rate is quite variable from person to person. We really try to treat each individual as an individual when we're planning their care, specifically with medications, certainly. But since we're talking really about people with the milder forms of Parkinson's early on in the diagnosis, exercise is recommended for all, but progression rates can really vary quite a bit. There are a good number of people after 2 decades will continue to have minimal motor symptoms and signs, and others who will be, a bit more disabled. And so there is really that variability, and we'll talk a little bit more about that. So what are the motor symptoms and signs of Parkinson's? And just to elaborate on those definitions, a symptom is something that a person experiences and will relate to you or to their doctor or to their caregiver what they're experiencing. A sign is something that we as doctors or others might elicit when we examine someone. But there's a lot of crossover between the two. And what are referred to as the cardinal motor symptoms and signs of Parkinson's are a tremor, which typically occurs at rest. So a tremor may start first in the upper limb, such as in the hand. Uh, More rarely, it can occur first in the leg, and sometimes it occurs in the jaw. And this is a tremor. We differentiate this from a different condition called essential tremor, because with Parkinson's disease, it's a tremor that comes out more when people aren't paying attention to it. Usually starts on one side of the body. Sometimes the tremor in the hand is referred to as a pill rolling type of tremor because the thumb is more involved. The frequency of the tremor occurs about 5 to 7 times per second, or that's the frequency is measured in hertz, but that helps us differentiate it from another condition such as essential tremor or dystonia. Tremor can really vary quite a bit in individuals, and it's a common early symptom and sign of Parkinson's, but it's not one that's typically too disabling to people when they get it. It can be a source of social embarrassment, but it's typically not disabling because that tremor goes away when people initiate movements to a large degree. So when they're bringing a cup or spoon to their mouth, or when they're exercising, that tremor often, you'll notice, will go away. What tends to be a bit more disabling for people are the slowness of movements that are another cardinal symptom of Parkinson's. So this term bradykinesia is Latin for slow movement, and so often it impairs people's ability to perform fine motor tasks earlier, such as doing buttons on their shirt, or handling keys, or cutting food with a fork and knife, or brushing their teeth. It's this finer dexterous movements that are impaired earlier on in Parkinson's, and they tend to not impair people too much with a lot of forms of exercise. But likewise, slow movement of bradykinesia can involve the legs, and so that can lead to a shortened stride length when people are walking, and eventually can lead to impairment in balance and can cause postural instability. Fortunately, though, for most people with typical Parkinson's disease, postural instability is not an early feature of Parkinson's. It's something that comes about later on. I don't really want to spend too much time differentiating Parkinson's disease from other atypical forms of Parkinson's, but this is probably a good moment just to mention that there are these other syndromes that appear like Parkinson's, but they have different names, and we really try to carefully diagnose or separate out atypical forms of Parkinson's from Parkinson's disease, because there are these other conditions, such as multiple system atrophy and progressive supranuclear palsy, just to mention two of them. They're much rarer than Parkinson's, but they can affect postural stability. They can affect balance to a much greater degree earlier on, so they can be a lot more challenging to treat. You likely will not have people showing up at these boot camps that are being formed who have these conditions, although it could potentially happen, but ideally patients should have gotten an appropriate diagnosis of idiopathic Parkinson's disease. And in their situation, certainly in the first 5 years of their condition, their postural stability should be fairly well maintained, and their gait and balance should also remain fairly good. So postural instability is considered another cardinal symptom or sign of Parkinson's, but not one that is affected to as great a degree, or it's predominant as much as slowed movement of fine motor tasks and the rest tremor. The fourth cardinal motor symptom and sign you'll see on here, and this is really a sign, not so much a symptom. It's rare that patients actually come to us complaining of muscle rigidity. It's something that we elicit on an exam in a specific way. Sometimes the term cogwheel rigidity is used because when we're examining patients, we feel rigidity when moving their hand up and down, or their elbow joint up and down at the wrist or at the knee joint, and we'll feel a cogwheel type characteristic of that muscle rigidity, and we differentiate that from other forms of rigidity such as spasticity, which patients who have had strokes or spinal cord injuries get. And that's really to help us more with the diagnosis. It's not so much, again, a symptom that patients complain of, although it can give us some guidance as to whether or not dopamine replacement medications are working, and when we're doing other things in the clinic such as deep brain stimulation programming, etc. But it's not something that we generally have to attend to as much as the tremor and slowed movement. So those are the cardinal motor signs and symptoms of Parkinson's that define the condition. And really, when we make a diagnosis of Parkinson's in the clinic, it's based on a really careful history, and asking about these symptoms, and then eliciting these signs on exam. There's not a separate diagnostic test still to this day that with 100% accuracy can diagnose Parkinson's. There is an imaging test called a DAT scan that has a pretty decent sensitivity and specificity, about 90%. So it'll be wrong about 1 out of 10 times. But this can at least separate out people with Parkinson's from essential tremor. That diagnostic test, however, does not do a good job differentiating Parkinson's disease from other Parkinsonian syndromes. And likewise, there's not a specific blood test or even a test in the spinal fluid that can make the diagnosis. So the diagnosis is based on a clinical diagnosis with a careful history and exam, ideally done by a neurologist, although often done by an internist or family practitioner, and possibly done by a movement disorder specialist, which is a subspecialty within neurology. So the non-motor symptoms of Parkinson's include changes in mood, and that can often predate the motor symptoms of Parkinson's. So they're not very specific for Parkinson's disease, but depression can predate onset of tremor and muscle rigidity by many years. I think anxiety is much less specific, and you probably, so it's very non-specific and can occur in patients who are having so-called motor fluctuations. We'll talk a little bit more about that. But apathy probably much more common than anxiety, where there's a loss of interest in certain activities and initiating activities, maybe a loss in not so much activities of daily living, but hobbies and things like this at home. Again, not specific for Parkinson's, but fairly prevalent. You see listed up here as well difficulty in swallowing, chewing, and speaking. That tends to be much like postural instability. It comes about much later on in the course of Parkinson's. Not very common in the first 5 years. I guess the exception to that would be one's speaking voice, so-called hypophonia, or softer speech, maybe an early symptom of Parkinson's. And so, like you will be working with these folks doing exercise, we often try to get patients into the hands of a specialized speech therapist who can work on increasing the volume of their speech. The autonomic nervous system can be affected in Parkinson's. The autonomic nervous system is a part of our nervous system that takes care of things such as gastrointestinal motility, our ability to urinate normally without hesitancy or urgency. And so urinary problems such as urinary frequency may come about early in Parkinson's. For men, erectile dysfunction may come about. Again, these aren't very specific for Parkinson's. And because the average age of Parkinson's is 65, often in an older population, these are pretty common problems anyway. Less so in people who are in their 40s or 50s, though. But probably of all those GI and urinary symptoms, constipation is the one, much like depression, that can predate motor symptoms and signs by many, many years. Not specific for Parkinson's, but considered a fairly common non-motor symptom. Difficulty with sleeping, again, not very specific. There's this one interesting sleep disorder called rapid eye movement sleep disorder, REM sleep behavior disorder, where people act out their dreams prior to the onset of motor symptoms. Normally, our muscles are paralyzed when we're in the dream phase of sleep, and that paralysis is lost as an early non-motor symptom of Parkinson's disease. That can help us, again, diagnostically, but not something you will probably be needing to attend to. And then you see here listed cognitive impairment. And so later, as Parkinson's evolves over many years, people can develop some cognitive impairment in the executive function. That is very important. You'll hear more from Dr. King about that and how that's addressed in exercise class, the ability to multitask, how that can affect one's gait, etc. It may just be some loss of memory. Again, in the older population over the age of 65 or 70, it's just the inability to recall proper nouns is most common, not very specific. But other memory difficulties may come about. And again, it's really the executive tasks and the ability to multitask that we find in folks with Parkinson's disease. So that's really a summary of both the non-motor and motor symptoms and signs that we use to make a diagnosis and that we really attend to treating when considering a number of treatments. So it's important to point out that we don't have a cure for Parkinson's and a way to really very effectively slow progression. There is evidence out there of ways to very mildly affect progression rates of Parkinson's disease, but we don't have a way to stop it in its tracks, unfortunately. So the mainstay of therapy for the motor symptoms and signs of Parkinson's is to help replenish the lost dopamine in the brain. And this can be done via a host of medications, as well as actually some nutrient supplements such as mucopurines. But really the mainstay of therapy is dopamine replacement. The milder medications that are both milder in their treatment effect as well as milder in terms of side effect are the monoamine oxidase inhibitors. These are drugs that block the breakdown of dopamine in the brain, such as rasagiline and selegiline. Then there are dopamine agonists, which have a bit more of a higher side effect profile, but they mimic the action of dopamine in the brain and have a more potent effect than monoamine oxidase inhibitors. And then sort of a gold standard of therapy is levodopa. Levodopa gets converted into brain into dopamine and has a much more potent effect to improve slowed movement, to improve muscle rigidity, and to help tremor. Many of your patients will not be on levodopa. The brand name is Cinemet, which is we give levodopa with another ingredient called carbidopa. It's something that many of us avoid in younger patients as an initial therapy. So you may have patients who are just on monoamine oxidase inhibitors, such as selegiline or rasagiline, or on that plus a dopamine agonist, but not on levodopa. But ultimately, every person who has Parkinson's, with all the treatments that we have available, eventually will end up taking some form of levodopa. A lot of people may not be for the first 5 years of their motor symptoms, and other people may be within a year or two, and it really depends on how fast their motor symptoms and signs are progressing. But levodopa, as I mentioned, gets converted into dopamine in the brain, and it can, when initially given, it can last seemingly half the day, right? And so we will give this medicine typically 3 times a day because its effective half-life is on the order of 8 to 10 hours. However, as Parkinson's disease progresses and as patients' own brain cells that make and release dopamine start to lose function, people depend more and more on this outside source of dopamine, and so its effective half-life, how long it lasts, gets shorter and shorter. And so while the initial phases of going on dopamine replacement with levodopa may last 7, 8 hours or longer, that can shorten to a span of 5, then 4, 3 hours, etc. And eventually can get to a point where patients are developing a wearing off of the treatment effect of their levodopa. And this can present certain challenges, and what's pertinent for your purposes are that patients may be relatively more, quote, Parkinsonian, may have slower movement, impaired stride and gait, more in the way of tremor and muscle rigidity, that comes out periodically throughout the day if they are on levodopa replacement. And so really when they're planning on an exercise class, we really want them to be in a quote-unquote on state. So this on-off term is used to describe patients who have Parkinson's disease who are already at a point where they're taking levodopa, but they may be getting a wearing off effect of their levodopa throughout the day. Again, in the earlier stages of Parkinson's, when patients aren't on any dopamine replacement therapy or are maybe only on an MAO inhibitor or dopamine agonist, they won't experience this wearing off. And even when they first start on levodopa, they may not experience it. But they may eventually get to a point where they are having wearing off, but still are very able to do an aggressive exercise program. And in that group of people, we really want them to be in their optimized mobility state when they're participating in exercise. So they have to consider taking their medication and timing for when they might do some of these exercises. And while in my practice, I often advise taking a stable dose with each dose of levodopa throughout the day, occasionally as the demands are needed, I may have patients take a slightly higher dose prior to anticipating a higher than usual demand, such as an exercise class or when they have something else going on in their life, maybe even socially, where they need to be on a higher dose. So that's something important to keep in mind. And if you've got questions about that, then I'm happy to talk about that. So exercise for Parkinson's, you're going to be playing a really important role in these folks' lives, not just to help maintain their sense of balance, but there's a large body of evidence now that early interventions with aerobic exercise may play a neuroprotective role in Parkinson's. And while those mechanisms still aren't completely understood, certainly there's a lot of evidence to that. There's a whole learning mechanism that occurs with the basal ganglia that is somewhat lost when patients lose this dopamine, and they get a breakdown of normal mobility. And so practice makes perfect, and with maintaining exercise and maybe even higher levels than one has done throughout their lifetime, you may preserve their ability to have this normal mobility that translates into the rest of their day and the rest of their week, even when they're not in the midst of an exercise class. So that may be one thing that's going on. There's also really um, cerebrovascular benefits, meaning that as people age, there are other risk factors that come into play that may impair their mobility. So it may be that maintaining a good cardiovascular health may play a role in helping people maintain compensatory mechanisms to maintain their mobility, maintain their balance, et cetera, that exercise, in particular aerobic forms of exercise and targeted agility programs, such as that are being taught through this boot camp, et cetera, can offer to patients. So I think I've gone through that somewhat here. For symptom management, I guess approaching non-motor symptoms, there's also evidence, certainly for mood and depression, that people do better, not just people with Parkinson's, but with routine exercise, that it can have certainly a sustained euphoric effect for a lot of people, and have an antidepressive effect. So for all these reasons, exercise is really paramount, and when we first see people in the clinic here at OHSU, this is part of the conversation we have with them, in addition to what to expect and what their dopamine replacement and other medical therapy might look like, that exercise and nutrition are key, and something that patients really can do walking out the door to really take hold of things and take control of their own situation, having just recently been diagnosed with Parkinson's disease. So I mentioned this already, but considerations for instructors who are working with people with Parkinson's. So for patients who are having any degree of fluctuation in effect with their medications, who are at that point, they really want to be told ahead of time to time medications so that they're in an optimized state when they're participating in an exercise class. This can come about with patients who are on dopamine agonists as well, and I didn't mention what the dopamine agonists are, but these are medications like pramipexole and ropinirole. Those are two that are typically prescribed. There's a third one called rotigotine, that's a patch. Have been now for a number of years extended release formulations of these medications. So some patients may be on those and may experience no so-called wearing off. And it's uncommon for people to have a wearing off feeling who are on dopamine agonists anyway. And it's really more particular for patients who are on levodopa therapy and who are starting to experience wearing off. Again, they may have had Parkinson's for more than 5 years, 10, 15 years, but when they're in a relative on state and optimized with medications, may still be excellent candidates to participate in an aggressive exercise program. When considering balance, this is obviously a big issue when participating in an exercise class. Postural stability is something that can be affected in Parkinson's. Uncommon for it to be a real issue from the first several years after one first develops motor symptoms of Parkinson's, but later on can be an issue. Typically in clinic, at least in a neurology clinic, this is assessed in person by the so-called pull test, where we'll have someone stand straight looking ahead with their feet squared about shoulder width. We'll stand behind them and let them know what we're going to do, which is reach in front of their shoulders and give them a pretty strong tug backwards, and asking them to step back and catch themselves within a step or two of being pulled. If someone's never had this done to them, of course, they'll probably fail, even someone without Parkinson's would, and may fall or may take multiple steps back. So there's a short learning curve. Once people have gotten used to this, they know how to react to it. And so people with more advanced Parkinson's may take many, many steps and not be able to catch themselves at all, or they may not be able to even initiate that first step, even with a more gentle pull. Those are people who have more impaired postural stability, and so they may be at greater risk, certainly, of falls when doing an exercise class. So you want to get a sense of one's postural stability, and you can always check back in with their physician and communicate with them to get a sense of that. You might consider yourself doing this kind of pull test as well. You obviously want to be in a position where you're able to catch someone or be backed up against the wall for support. If someone is larger, weighs a lot more than you, I can imagine, for example, Brian Grant himself in doing a pull test. and if you didn't have the postural stability, so someone of that size. So you want to take all these things, of course, into consideration, right? But assessing one's balance, that's something that routinely can be found in medical notes in a neurology clinic. Now, someone who might be just being managed by a primary care physician where this specific test hasn't been done, or the so-called push test, or there are all kinds of other monikers given for these tests where someone may lean against your palms, again, backwards, and then you release your palms. There's another way to do this test. You may not have that data, and so you may want to come back to the physician first before they've even signed up for class. Or really, it may be just as simple as asking patients if they're struggling with balance, if they've had any falls, and you can just get that information from them up front. Likewise, with gait, some changes that can occur with walking and with gait include shorter strides, a shuffling quality to gait, and then something else to be aware of is this term festination and a festination of gait. And what that is a scenario where when people start to walk and have initiated their movement, they then have difficulty stopping. So they may get shorter and shorter stride length and take multiple steps, but then they're not able to stop themselves, and that can lead to a fall. So whereas people with Parkinson's who have postural instability may have a tendency to fall backwards more often, people with a festinating type gait may have a predilection to fall forwards. And that's something that you can just ask them about, or you might just observe in class. So people with a lot of fascination or with real postural instability are probably not going to be good candidates for the boot camp, but you want to know about these issues. And again, these are things that come about later on in Parkinson's and not earlier. Finally, you'll see here another consideration of low blood pressure. A term we use is hypotension, and really the changes we see in Parkinson's are orthostatic hypotension. And what that means is orthostatic, meaning they go from a sitting or lying position to a standing position, and then their blood pressure drops. For most of us who don't have Parkinson's, and for many who do have Parkinson's, this is not an issue. And when we stand up, we may get a little bit of a drop in our blood pressure, but then there's typically a compensatory increase in heart rate or pulse, and so that we don't get dizzy or lightheaded when we stand up. But some of that compensatory response can be lost in Parkinson's, and so there can be a drop in blood pressure, and typically the sort of definition of orthostatic hypotension is when there's a drop in 20 points or more systolic or 10 points or more diastolic blood pressure without a compensatory increase in a heart rate, and that can lead to a feeling of near passing out. And in a more severe situation, it can lead to people actually passing out when they stand up. They're more prone to this after meals, after a big vagal maneuver such as a big bowel movement, or if they've just been spending a prolonged period supine, lying down, such as first thing in the morning when they get out of bed. And so this is something we routinely check here, and other movement disorder clinics routinely, I think, probably check for folks with Parkinson's if they're prone to this. This may not be something that's routinely checked for, though, by a primary care provider, so just something to be aware of, and you can get at this history just by asking people when they stand up if it's common that they feel lightheaded. I think lightheaded is a more accurate term than dizziness. Dizzy is a much less specific symptom, but lightheadedness might describe orthostasis, and this is something that any doctor's office or even anyone at home could check by getting we routinely do a sitting and standing blood pressure. It's also important to be aware that people who are on dopamine replacement therapy, in particular levodopa, can exacerbate this condition. Often we lower the dose of their Sinemet, their levodopa, if they're having a lot of orthostatic blood pressure changes. Ways to prepare for an exercise class, if this is someone's experiencing this to a mild degree, and it's not severe enough to keep them out of an exercise class, is to make sure that they're properly hydrated before participating in the class, and not just hydration, but salt replenishment too. So this can be done with sort of these exercise beverages that are out there, Gatorade, etc., that have electrolytes in them. A cheaper way for a lot of people or easier access really is just sodium chloride salt. So people who don't have high blood pressure chronically, but have a bit of orthostatic hypotension, want to stay adequately hydrated and then just salt their food. And we tend to pay more attention to this in the summer months when it's hotter, people sweat more and they're more prone to getting this problem. But certainly before an exercise class, we want to know that they're well hydrated and have appropriate salt intake prior to this. Another thing you might consider is patients wearing support hose or support stockings that can help venous blood return from their lower limbs, and that can also counteract orthostatic hypotension. And that may be something, while they may not need it throughout their normal day, it might be helpful for them to use during an exercise class. So when considering mild cognitive impairment that can occur in folks with Parkinson's disease, um, there are, so a lot of work's been done with mild cognitive impairment, a lot of research and problems with gait and balance. In fact, now we have evidence that people who take cholinesterase inhibitor medications, such as Aricept and Exelon, et cetera, can actually help with gait and balance. With gait and balance, using visual cues can help people with these problems, including people who are having gait freezing. I'm not going to spend too much time talking about this because you'll hear more from Dr. King next week in her webinar. Hopefully you'll all tune into that. But there's a number of external cues, and not just visual cues, but auditory cues. Dance is a great therapy for people with Parkinson's too, and some of that's based on the auditory input they're getting. The basal ganglia, the circuit I alluded to that breaks down in Parkinson's disease, not only is responsible for automaticity of movements and its output, but is really finely in tune to its inputs. And so we always are looking for compensatory mechanisms using both visual and auditory cues. And so this is something that can be incorporated into exercise classes too. And so these dance classes, for example, for Parkinson's are using just that with auditory cues. Another consideration you see on here is disease progression. So I mentioned there's quite a bit of variability with progression of disease for different individuals with Parkinson's. It's not a one-size-fits-all. Probably that's due to different causes of one's Parkinson's relating to what their progression rate is like. You just need to be aware of it, and knowing that if someone enrolls in your exercise class and they're a great candidate at a given time, that as the years go by, and if you you continue to do this over years and you have the same participants over years who are participating in your exercise class, they may not be fit in 1 or 2 or 5 or 10 years to be doing the same level of exercise that they once were, and you just need to be aware of that. And it may be checking in with patients and caregivers, checking in with their healthcare team, including their doctors and their physical therapists. Physical therapists will be a great resource for this to give you a sense of to what degree of progression there has been. If you have any questions, you should check in with their healthcare team about that. I think with that, we've kept this a pretty simple introduction to Parkinson's, but happy to open things up to questions to you all now.
Great, thank you, Dr. Brodsky. So I'm going to go ahead and unmute the lines and see if people have any questions that they would like to give to Dr. Brodsky. As I mentioned earlier in the call, we will go over a lot of this information again in the training on November 5th, including we have information on how to kind of assess patients for certain things and some of the other topics that Dr. Brodsky brought up. But like I said, we'd just like to take the last few minutes to hear from all of you and ask if you have any questions of Dr. Brodsky. Your lines are unmuted if you would like to ask him any questions. Well, maybe we did such a good job of overview of Parkinson's that you guys feel good to go. Before we leave today, I